Okay, welcome everybody. Thank you so much for coming. You're in for a great treat. We have a wonderful speaker tonight. My name is Leah Groppo. I'm one of the clinical dietitians and diabetes educators at Stanford Healthcare. And I have the great pleasure to introduce Michael. Michael Blumen is an ambulatory care clinical pharmacist at Stanford Healthcare, primary care, working in the primary care and endocrinology space. Michael completed his PharmD at UCSF School of Pharmacy and residency with an emphasis in ambulatory care at Stanford Healthcare. He is a certified diabetes education and care specialist and serves as a Stanford Healthcare ambulatory care pharmacy residency program coordinator. Outside the clinical practice, Michael is a clinical advisor for MedHug Inc., seeking to improve patient outcomes by providing healthcare systems with transparency on Medicare prescription coverage. So we're so lucky. If you have any questions throughout this presentation, please feel free to put it in the Q&A, and we will answer them as they come in. So thank you so much. Without further ado, Michael.
Thank you, Leah. It's great for everyone to join us today. Today, our topic is GLP-1 receptor agonists, the truth behind the trend. These are a hot topic these days in diabetes and weight loss management. To add a little bit on to what I actually do day to day, I spend at least 40 hours a week in the clinic treating patients, and I would say a majority of that is diabetes management. So I'm very familiar with these medications, and I hope that I can impart some of this info over to everyone on the call today. So let's get started. So we have 4 main topics we will cover, and we'll definitely have room for questions, so I don't think I'll be talking for the whole hour. We'll start with GLP-1 pathophysiology and pharmacology. We'll move on to the GLP-1 receptor agonist medications. We'll talk about the benefits and risks of the medications, and we'll also talk about their use within diabetes management. So let's get started on our first section. This is a sort of brief breakdown of what happens with food and sugar in the context of diabetes. So our cells need glucose for energy and for function. Glucose is sugar, and we get sugar from 2 places. We get sugar from our liver, and we get sugar from anything we eat that contains carbs. If you eat something that contains carbs, it'll be digested into glucose. If your liver pumps it out, it'll go directly into the bloodstream. And from there, our body will send a signal to release insulin. Once insulin's in the bloodstream, it sees the glucose, presents it to the cell, and in an ideal world, the cell will intake the glucose and get that sugar out of the bloodstream and use it. Now, we know in diabetes that is impaired. In type 2, it's resistance is the main issue, where the insulin may present the sugar to the cell, but the cell doesn't really take it, and thus the sugar is still high in the bloodstream. There's also a bit of a production of insulin issue potentially going on. Both of those things lead to higher blood sugar. So that's what we see here. Peripheral insulin resistance. This is where in the muscles, fat, and liver cells, we do not respond effectively to insulin. It's there. It's just not really allowing that sugar to get into the cell, and thus we have high blood sugar. Or reduced insulin secretion. That's where we have a little bit less insulin production, and of course, if there's less insulin, it doesn't match how much sugar is in the bloodstream, and thus the sugar is high in the bloodstream. So these are the number of factors in type 2 diabetes that lead to this high blood sugar. We talked about insulin resistance and decreased insulin secretion. There's also increased carbohydrate intake. So if we have a lot of carbs, another thing that we look at is an increased amount of glucose production in the liver. And this is as a result of a misbalance in what's called glucagon, which is the opposite of insulin. Glucagon is a hormone that makes us secrete sugar. So what is the role of GLP-1, behind this whole background of diabetes? GLP-1 stands for glucagon-like peptide 1. It's what's called an incretin hormone. And it's produced in the intestines, and it's released in response to food intake. It has a number of functions. First, blood sugar regulation. GLP-1 in the body stimulates pancreas to release insulin, and especially after eating, which of course will decrease the sugar eventually with that increase in insulin secretion. It inhibits glucagon. So as I was just mentioning, glucagon you can think of as the opposite of insulin. Glucagon tells our liver to release more sugar. So GLP-1s inhibit glucagon and thus reduce the amount of sugar our liver secretes. Another thing GLP-1 does is it slows gastric emptying. So it slows down how fast food leaves the stomach and enters the intestines, which generally reduces appetite and makes you feel full. It also reduces the rate of glucose absorption. Also, it promotes satiety, so the feeling of fullness. And that's through the GLP-1 receptors in the brain, and thus that also reduces appetite. The appetite reduction parts of its mechanism do contribute to weight loss when we think about the medications that mimic this hormone. But also it can decrease sugar as generally it reduces how many carbs we intake. So that's the role of our naturally occurring glucagon-like peptide 1 incretin hormone in our body. Here's a graphic to sort of better maybe convey the things we talked about. In the pancreas, it increases insulin secretion and decreases glucagon, both which result in lower sugar in the bloodstream. In the stomach, it decreases motility and emptying, promotes a feeling of appetite fullness and appetite suppression. And in the brain, similarly, increases satiety, which again decreases our appetite. The GLP-1 hormone, it binds to its receptor. Its receptor is located in a few different parts of our body, primarily the brain, the intestines, the liver, the fat tissues, the kidneys, and the heart. So this is how it physically actually works, right? When GLP-1 is released in the bloodstream, it finds its receptor. Once it binds to the receptor, it produces all of those effects that we just spoke about. So then what is a GLP-1 receptor agonist, right? The heart of the issue today. GLP-1 receptor agonists are medication that are mimicking that GLP-1 hormone. They are binding to that receptor and amplifying the effects of the GLP-1 hormone. So it's kind of like replacing or maybe supplementing our natural GLP-1 hormone. And again, as a result of that, it will have the same effects as our GLP-1 hormone in terms of blood sugar regulation, inhibition of glucagon. So again, helps with blood sugar, slowing gastric emptying, and promoting satiety. So let's get familiar with some of these GLP-1 receptor agonist medications. Here is an overall view of how the landscape looks in terms of FDA-approved GLP-1 receptor agonists. Sometimes we call them GLP-1 RAs, just for short. In the bold, you will see the generic name. Above it in big letters, you will see the brand name. So exenatide, the generic, there's Byetta and Bydureon, there's lixisenatide, Adlixin, there's liraglutide, which comes as either Victoza or Saxenda. Dulaglutide is Trulicity. Semaglutide is either Ozempic, Rybelsus, or Wegovy. And tirzepatide is either Mounjaro or Zepbound. Those are the current approved GLP-1 receptor agonists, the brand name, and their corresponding generics. Of note, none of these are generic except for liraglutide. That being said, it's still quite pricey as a generic. In terms of the differences between these, one easy way to separate the differences is how they are taken. And there's only one oral GLP-1 receptor agonist that's approved. That is Rybelsus, and it's a daily oral tablet. There are injections that are either daily or weekly. Now, to be honest, most people use weekly injections. It's easier to do, and they tend to have more robust data. They're also newer. But the daily injections are still out there. You can get Byetta, Dlixen, Victoza, or its generic, Saxenda. But the weekly ones are the ones we hear most about because those are the ones that are most commonly used. Obviously, it's easier to inject something weekly versus daily. So that's Bydureon, Trulicity, Ozempic, Wegovy, and Zepbound. Also, Mounjaro should be on there. What do these injections look like? How do they work? This is often a question I get when we discuss starting a medication like this. GLP-1 receptor agonists are injected subcutaneously, meaning under the skin and into that fatty layer of tissue just below it. So this is not going into the muscle. This is not a very big needle. For anybody who uses a GLP-1, they can attest it is quite a small needle. It's quite thin, usually like a 34 gauge. 31 gauge, and also they're only 4 to 5 millimeters long. To be honest, if I had one on screen right now to show you, you probably couldn't see it through the camera. It's injected at a 90-degree angle and most commonly in the abdomen or thigh or back of the upper arm. Most people choose the abdomen or thigh. It tends to be easier. So in terms of what they are used for, these medications are primarily diabetes medications. They were initially discovered and initially indicated for diabetes. What we came to find is they're also very good at weight loss, and thus some of them have also been separately approved for weight loss outside of diabetes. So if you look at the left, these are all of the medications that are approved for diabetes, and thus if your doctor is giving them to you for diabetes, these are the ones that will be used. Of note, things like Ozempic and Mounjaro, and Victoza, these are diabetes formulations. Now, separately, like I said, there are weight loss formulations. If you want to use these medications without a diagnosis of diabetes, you would need to meet the criteria for weight loss and have that indication. And the 3 that are used in that form are Saxenda, Wegovy, and Zepbound. Again, these are not different. In fact, they all have a cousin next door that we use for diabetes. It's just sort of separate brands for separate indications. So for example, liraglutide, which is sold as brand name Victoza and now recently available as a generic, is indicated for type 2 diabetes. It's dosed daily in a pen, as you see here. And the doses are 0.6, 1.2, or 1.8 milligrams. And it comes in a preparation that will last potentially 10 to 30 days, depending on the dose you use. Saxenda is indicated for chronic weight management. Now, it's the same exact drug. It's both liraglutide, but Saxenda's dosing goes a little higher. It goes to 2.4 and 3 milligrams. Those doses are not approved for diabetes management. And again, the preparation is the same, but the pen will last 6 to 30 days, again, depending on what dose you use. Semaglutide has a few different formulations, but we think about injectable semaglutide, so not Rybelsus. We have Ozempic and Wegovy. Ozempic is indicated for diabetes. It's dosed weekly, and the dosing is 0.25, 0.5, 1, and 2 milligrams. And the preparations, it comes in a few different formulations, which essentially means regardless of what dose you're on, you get a 4-week supply. On the other hand, Wegovy is the exact same drug. It is also semaglutide, but it is indicated for weight loss. And the dosing is slightly different. You have 0.25, 0.5, and 1. Those are all in common. Then you have 1.7 and 2.4 milligrams. Those are not available in Ozempic and are not used for diabetes management. That being said, it's a very similar range. The pens are slightly different. Wegovy is a single-use injection. So you use one, and that pen is done. And you get 4 in a box for 4 weeks. And then we have tirzepatide, which is brand name Mounjaro or Zepbound. Now, I did want to call out tirzepatide a little bit separately because it's actually a one-in-class medication. We've been talking about it like a GLP-1 receptor agonist, but in fact, it has 2 mechanisms. It has the GLP-1 receptor agonist part to it, but it also has a GIP receptor agonist part to it. And it's the only medication that can bind both of these receptors. Now, what's the difference between the two? So GIP stands for glucose-dependent insulinotropic polypeptide. GLP-1 has more effects on reducing glucagon and promoting satiety, which means it has more effects on reducing how much sugar your liver secretes, and it promotes that feeling of fullness in the brain. GIP has a little bit more effects on insulin secretion to get more of that insulin in the bloodstream, and it has some effects on fat and bone metabolism. And you can see sort of that graphic displayed here, where you have GIP's effect on the left, GLP-1's effect on the right, and then there's some overlap. There's, these are not very different hormones, but they do have slightly different effects based on where the receptors are located. So tirzepatide, which is in Mounjaro and Zepbound, it hits both of these receptors. Mounjaro is the diabetes version. It's only indicated for diabetes, and as weekly dosing, it's an injectable medication, and it has several steps in dosing. It starts at 2.5, then you have 5, 7.5, 10, 12.5, and 15. So very incremental when you compare it to the other weekly dosing options. And you have Zepbound, which is exactly the same. It has the same doses available, prepared in the same type of pen, a one-time use pen. You get 4 pens in a box for 4 weeks. The biggest difference is that Zepbound is also available in a vial if you wanted to use a syringe and vial method. It's a little bit cheaper. So now that we have a background understanding of how these drugs work, what they're mimicking, how that plays into the diabetes world, and which drugs are available, let's talk a little bit about the benefits and risks. I think this is at the heart of the conversation of why should I use this medication potentially. So the class benefits, the benefits that all of these medications present, for the most part, is a significant reduction in blood sugar and A1C. Of course, those are correlated. Very minimal hypoglycemia or low blood sugar events, especially when you compare them to something like insulin or things like glipizide or glimepiride. Very minimal hypoglycemia. Weight loss. Some of them have been shown to reduce cardiovascular events, so promote cardiovascular health. Some of them have been shown to reduce the rate of kidney disease and kidney injury, which of course is always top of mind when we think of the risks of high blood sugar. Also, some of them have shown benefits in non-alcoholic fatty liver disease. Also, it's been renamed to sort of metabolic, I think it's metabolic associated steatic liver disease. So essentially liver disease that stems from some of these metabolic conditions. So you can see there's a number of benefits that GLP-1s produce that are not exactly only blood sugar control. Now, when we look through the different products, they obviously have slightly different ability to exert these effects. So first, let's talk about glycemic control, blood sugar control. Here we're talking about Ozempic, which is injectable semaglutide. And we're looking at one of its early trials, the SUSTAIN-1 trial. It compared Ozempic at 0.5 and 1 milligrams against placebo. It was a 30-week trial with 388 patients who have type 2 diabetes. The mean age was 54, 54% were men, and the average BMI was 33. And when you look at the trial, you will see, one, that at the end of it, at the 30-week mark, the baseline A1C went down by about 1.6% in the 1 milligram group versus 0.1%, virtually no difference in the placebo group. And when you correlate that to their average sugar, their fasting blood sugar, it went down about 44 points. This is in 30 weeks on the 1 milligram dose. This is a graphical display of that. So that light pink line on the left is placebo, and then you have your green and blue line. The blue line is 0.5, the green line is 1. And you can see the vast difference it creates in the A1C between the two. The importance of showing this graph is to show how the blood sugar is reduced and how the A1C sort of moves. You can see that there's a pretty steady decline in those first weeks. And that's because you're moving through those doses. You're moving through 0.25, 0.5, and for the 1 milligram group, they're going to 1. So there's a constant dose increase through those first few weeks. And when you're stable on one dose, you can see after some time, it sort of plateaus. So after about 2 months on the same dose, the effects are much more gradual. And when I talk to patients day to day in clinic, this is the reality that you see with the effect of the medication. Once you reach a steady dose, whatever your target dose may be, the blood sugar will sort of plateau. That is where its max effect lies. And that's why this curve is very important to remember when you think about how this medication will affect your blood sugar. There was also the SUSTAIN FORTE trial, which showed Ozempic 1 milligram versus 2 milligrams. And again, this is a placebo-controlled trial, and now it was at 40 weeks with 960 patients. And here what we see is in the Ozempic 2 milligram group, you can get up to a 2.1% decrease in the A1C, which would result in about a 59-point difference in fasting blood sugar, which is quite a big difference. So it's to show that Ozempic is really quite potent in its effects, one of the most potent medications we have for blood sugar lowering. And again, this is that curve we see on 1 versus 2 milligrams on the A1C, and you see a very similar pattern, a very steep decrease in the beginning as patients move through doses, right? Each dose takes 4 weeks to move through. So if you think about people on the 2 milligram dose, that lighter blue line, it would take them at least 16 weeks to move through all of those doses. And as they go past the week 20 mark, when they've been stable on the same dose, things do sort of plateau. Now, I mentioned semaglutide, the same active ingredient Ozempic, also comes the oral version, which is Rybelsus. So this is the PIONEER 1 trial, which took that oral semaglutide, also known as Rybelsus, in the 7 milligram or 14 milligram form, which is the 2 therapeutic doses available, and it compared it against placebo. It's a 26-week trial, 703 patients with type 2 diabetes. What you see is at that 26-week mark on the highest dose, the difference in A1C is about 1.4%, which is about 33 points in the blood sugar. Still a great effect. And we can't compare one trial versus the other because there are a lot of factors to consider and variability to consider, but you can tell overall not as potent as the Ozempic at that highest dose. And again, you look at the curve of how that A1C went down, and you see a very familiar style curve where things sort of start to plateau as people reach a stable dose. It takes 30 days essentially to reach a stable dose on Rybelsus, and thus you're looking at that 60-day mark, so about 8-week mark and 12-week mark, and it starts to plateau after that. Next, we have Trulicity. Trulicity is dulaglutide, again, another one of our weekly injectable medications. And here we have the Award 11 trial, and it compared a 1.5 milligram dose of Trulicity versus 3 or 4.5 milligrams. 4.5 milligrams is the current max approved dose of Trulicity. And it's a 52-week trial with 1,800 patients roughly. And again, you see the effect in this graph. And what you see is that at that 52-week mark, it's not too dissimilar from the 36-week mark, you get about a 1.8% difference in the A1C from baseline. So pretty effective. And when you look at that blood sugar A1C change on the right, same type of curve. A very steep decline when it was titrated. And again, it takes 4 weeks on each dose. So once you pass that 12-week mark and people sort of hit those last doses for the first time, things do not change too significantly after there. Next, we have Mounjaro, which is our tirzepatide. We talked about that, the only one in class that can hit those two different receptors. It's also the newest one. Again, weekly injectable medication, and we're looking at the SURPASS-2 trial. And here it compared the Ozempic at 1 milligram to 3 different doses of Mounjaro and a 40-week trial with 1,800 patients. And what you see is at that highest dose, Mounjaro can reduce the A1C by up to 2.3% on average, which is about 60 points of blood sugar. It's really one of the most potent reducers of blood sugar that we have, of course, outside of insulin, because insulin, the higher the dose, the more it will decrease the sugar. And so it showed very, very good effect. And you can see that as the doses go up, the effect increases. And when you look at how it does it over time, you can see that as you approach that 6-week mark, it takes about 6 weeks with Mounjaro if you continue to raise that dose. Sorry, not 6 week, 36-week mark. Things tend to plateau. So that's for blood sugar control. What we saw was these are very effective. Some are a little more effective than the other. The oral Rybelsus, although it's nice not to have to inject, may not be the most potent, but still able to reduce sugar. And we saw that it sort of plateaued once you hit your target dose. Now, one of the other major class effects that people use this medication for is weight loss. So let's look a little bit about the weight loss effects of these medications and what's been shown in trials. So again, this is Ozempic, back to our SUSTAIN-1 trial, the same one we looked at initially. And you can see here, the average BMI was 33, and the overall average baseline weight was 91 kilograms. So let's say probably a little bit over 200 pounds. And the difference on the 1 milligram, 0.5 milligram, and placebo can be seen in the graph. So on the placebo, people lost almost 1 kilogram. On the 1 milligram dose at 30 weeks, they lost about 4.5 kilograms. So that's upwards of 10 pounds. And about 5% body weight in that case, if 91 is our baseline. And what's important to see, again, is the style of curve that's produced in this data. You can see that, again, things start to plateau a little bit more when you're on that stable dose versus when you're titrating and increasing the doses and you're only experiencing the medication for its first 4 weeks. After about 8 weeks on the same dose, things tend to stabilize. Now, when we look at the SUSTAIN-FORTE trial, which looked at the higher dose of Ozempic, 2 milligrams, you can see a little bit more of an effect. People lost almost an average of 7 kilograms, close to that 10% of body weight mark. So, 7 kilograms is maybe closer to like 16, 17 pounds. And again, it plateaued, but a little bit less. Again, this is only a 40-week trial, but it did start to plateau as people reached that final dose. When we look at Rybelsus, that oral version, we remember that in the blood sugar control portion of these trials, it was good, but a little bit less potent than our injectable medications. And we see a very similar thing when we look at weight loss. It's still hitting those same GLP-1 receptors, so it still has that class effect. However, may not be as potent. And here what we see is the average body weight change in this 26-week trial, and granted 26 weeks is not a whole ton of time, is about 3.7 kilograms. So nearly 10 pounds, a little less than that. When we look at Trulicity, the AWARD-11 trial, you can see a very similar style curve. Things start to plateau as the dose reaches its final stages. And on the Trulicity, the mean weight to start was 95 kilograms, and people lost almost, they lost almost 6 kilograms on that highest dose at 52 weeks. So maybe not the strongest weight loss version of these types of medications when you compare it to what we've started to see with Ozempic. Now, when you look at something like Mounjaro, tirzepatide, and you look at the SURMOUNT-5 trials, it's 12 months, so again, 52 weeks, 1 year. These are its effects in percent of body weight. So nearly 20% body weight reduction at the 12-month mark when you look at that highest dose. And the other thing that this trial did was compared it to Ozempic. Ozempic is the dark blue, Mounjaro is the light blue. And you can see that at every point, Mounjaro produced more weight loss than Ozempic in this particular trial that lasted 12 months with almost 18,000 patients. So when we think about 20% of, or this is a little bit less, but when we think about 20% of body weight on a mean weight of 110 kilograms, you're looking at probably around 20 kilograms. That's about 44 pounds on average people lost in this trial on that high dose 15 milligrams of Mounjaro. And that was more than what we saw with the Ozempic, which was about 10% body weight, so maybe more like 10 kilograms. So that's the weight loss part of it. So from the blood sugar and the weight loss, you see a pretty good correlation that the versions of GLP-1 receptor agonists that promote a lot of weight loss, they also go hand in hand with the ones that have really good blood sugar control. Mounjaro being on the most potent side of things, along with high-dose Ozempic. Then you have things like Trulicity, and sort of the lightest weight ones would be the oral semaglutide, the Rybelsus. Again, it's hard to compare trial against trial. There's a lot of factors to consider, but that's the general trend we see between these different products. Now, as I mentioned, blood sugar control and weight loss are not the only benefits these medications can provide, and why GLP-1 receptor agonists are so widely used in diabetes, because they have a whole host of different benefits. Some GLP-1 receptor agonists have been shown to have cardiovascular benefit. In particular, Victoza, Ozempic, Trulicity, these are all diabetes-indicated GLP-1s, have been shown to reduce cardiovascular events in patients with type 2 diabetes. And for Trulicity and Ozempic, this is proved in patients without a history of cardiovascular disease. For Wegovy, which is a weight loss version of Ozempic, it's also been shown to reduce major cardiovascular events in overweight, obese individuals with pre-existing cardiovascular disease. Typically, the way this is done is through a long-term trial where we're looking at risk reduction in a endpoint score. This score is composed of 3 things: non-fatal heart attacks, which is myocardial infarctions, non-fatal strokes, and cardiovascular death. So if it can reduce the composite of those scores, then it can claim the cardiovascular benefit. And so when we look at Ozempic, for example, in the SUSTAIN-6 trial, a clinical trial that went on for 2 years, 3,200, almost 3,300 patients. They had type 2 diabetes with established cardiovascular disease or risk factors. Risk factors can be things like high blood pressure, obesity, some sort of atherosclerosis in the cardiovascular space. So when you look at this trial, what you see is in the dotted line, the placebo arm, and in the regular line, the Ozempic arm. And what you can see is a 26% lower risk in the first occurrence of this composite score. So the first occurrence of either a heart attack or stroke that was non-fatal or cardiovascular death. To give people a perspective on what this actually means, a meta-analysis of aspirin, an analysis of 13 different trials of aspirin, has a 11% lower risk score for the same endpoint for primary prevention, so the prevention of the first occurrence of one of these events. So that kind of gives you an understanding of really Ozempic has a very good ability to preserve cardiovascular function by preventing these types of events from occurring. When you look at kidney benefits, Ozempic recently was approved to help preserve kidney function, and it's shown to reduce the risk of important kidney outcomes like death from cardiovascular causes in patients with type 2 diabetes and chronic kidney disease. This is called the FLOW trial that compared Ozempic 1 milligram versus placebo. It was a 4-year trial with 3,500 patients. And again, these are patients with type 2 diabetes and chronic disease. And again, when you look through the trial, the primary outcome was this composite score. And what the composite score was made of was the first onset of kidney failure, a sustained reduction of at least 50% in the kidney filtration rate, so basically lower kidney function, or death from kidney-related or cardiovascular causes. And when you look at Ozempic versus placebo, it had a 24% lower risk in the first occurrence of one of these major kidney disease events compared to placebo. So before we move on to the class side effects and risks, you can see that there is a number of reasons why these GLP-1 receptor agonists may be go-to medication. And a lot of that is dependent on a person's specific medical history. The need to lower blood sugar, the need for weight loss, the need for protecting the heart or the kidneys, potentially the liver as well. So they have a lot of different areas they work on that are related to overall diabetes health. Because again, the whole point of diabetes management and lowering sugar is to prevent damage to the heart, kidneys, eyes, nerves. And this certainly hits on some of those different points. Now, there's always risks, right? It's always a benefit-risk equation. So these are the class side effects and risks. Of note, there is not one GLP-1 when compared to another that has had significantly more of this issue than another one. The most common side effect with these medications is nausea or abdominal pain, constipation or diarrhea. This is dose related, so often occurs more at higher doses. And it may be a result of the effect of these medications in delaying gastric emptying, meaning slowing down how fast food leaves the stomach. Often we ask patients to have smaller, lighter meals when they start or change doses, because it's very easy to sort of get over full and overeat, as people are not used to the smaller appetite that these medications produce. There's also an increased incidence of diabetic retinopathy. Again, now this is mostly seen in pre-existing diabetic retinopathy, so patients that have this already, and in coordination with very fast reduction in A1C or very fast reduction in the blood sugar. Again, it's always important to do it in a stepwise fashion, increase these medications along with your provider in a very measured way to ensure you tolerate it well, but also avoid things like this. There is a very rare risk for gallbladder disease. This is related to the dose you take and how long you take it. Often it's weight loss related. And typically people with already pre-existing gallbladder disease, we may not use these medications to avoid making anything worse. And so it's always important to be screened to make sure that you're actually a candidate for something like a GLP-1. Now, we talked about how Ozempic, which is the only one right now, but likely others will follow, has some benefit in the kidneys. But there is on the labeling a note for acute kidney injury, which is sort of counterintuitive. What the acute kidney injury note is related to is mostly dehydration. And mostly that dehydration is due to any severe nausea that can happen from the medication, which can result in vomiting. Anytime you're dehydrated, and especially if that comes in concert with lower blood pressures, your kidney will struggle. So it's always important to stay hydrated to ensure good kidney health. And in these cases where people were so nauseated that they had vomiting, you can see that they also had acute kidney injury. But if you avoid those, work closely with your team to ensure that before you move on any dose, you tolerate it well. And if you're not tolerating a dose well, you either step back or you completely stop the medicine. You should be able to avoid this. Now, lastly, are two very rare risks. They often, they often get pointed out, but I honestly wouldn't be too worried about them unless you meet specific criteria. So one is pancreatitis. These medications have a very rare risk for causing the inflammation of the pancreas. Now, mostly this is not an issue. What we do have to watch out for is anybody who has a pre-existing history of pancreatitis or anybody that has already existing risk factors for pancreatitis, which include chronic alcohol use and elevated triglycerides. And often elevated triglycerides come in combo with very high sugars. So diabetes itself puts you at risk for pancreatitis. Again, and when you don't consider these risk factors, the risk is very rare. Lastly, there's a black box warning for, or a boxed warning for medullary thyroid cancer or thyroid T-cell tumors. This was seen in early drug development with rodents. This has not been seen in primates, and as far as I know, not been noted in studies in humans. One of the theories is rodents have much more C cells than humans and primates do. And also, humans have a very low expression of GLP-1 receptors within these C cells. So although this is a boxed warning, and you will see it on the labeling when you look it up, I would say this is a very, very unlikely outcome. Overall, when you think about starting any medication, you always have to think about benefits and risks. And so both sides of the equation need to be considered, whether you are a true appropriate candidate for the medication to avoid these risks, and how much benefit you will get out of starting a medication like this based on the benefits we talked about earlier in this section. Lastly, I wanted to sort of make it a little more practical. We talked about benefits and risks, but how does this fit into diabetes management? How do we choose who should be on this medication, who will benefit the most? This is a quick picture of the American Diabetes Association clinical guidelines, and it sort of gives an idea as to where the evidence points to the best benefits for certain medication. And GLP-1 receptor agonists are all over this thing. So the first thing you see is that anybody with atherosclerotic cardiovascular disease, so things like heart attack, stroke history, angina, blocked arteries, things like that. These are first-line medications. Preferably, we use the ones that have proven cardiovascular benefit, things like Ozempic or Trulicity. And these are preferred because not only will they lower the sugar, they will also help mitigate that risk of cardiovascular disease. You will also see it in the chronic kidney disease section, where anybody with chronic kidney disease should be started either on SGLT2, a different class of drugs, or if they can't or don't tolerate it, a GLP-1 with proven kidney benefit, which would basically be Ozempic at this point. When you look at some of the other factors as to why you might pick a medication, here is efficacy for weight loss. So if weight management is a desire of our patient, or we feel it would be beneficial, certainly GLP-1s need to be looked at because they produce the most weight loss out of any of the diabetes medications. And not only that, we also know which ones tend to produce the most weight loss. And that's where these are stratified. You can see very high semaglutide and tirzepatide. This would be high-dose Ozempic or high-dose Mounjaro. Then you see things like Trulicity or Victoza, and then you see basically everything else. You also see if there is a need for glucose lowering, like a big need, we want to lower the glucose a lot, not by just like 15 points, maybe by 60, 90, 120 points on average. The GLP-1s are at the top of that list. In particular, high-dose Ozempic and Mounjaro have been identified as basically the most potent versions of GLP-1s when it comes to lowering sugar. And we saw that directly when we looked at the trials. Lastly, to mitigate liver disease that's related to metabolic conditions, previously known as fatty liver, that's not alcohol related. The guidelines also talk about the use of GLP-1s. Now, there's not a lot of robust trials for GLP-1s in the space. Ozempic does have some small data. They're not indicated for this, but we have seen that the use of these medications tends to improve the markers of liver disease that can then turn into things like liver scarring and eventually even more extreme consequences. So the point of this section is to show you that all of those class benefits we saw are considered when we discuss which medication may be the best for someone. And the nice thing we see in GLP-1 receptor agonists is not only are they very good at lowering blood sugar, but they can also hit a lot of other components in comprehensive diabetes management that are important to consider. Things like kidney health, liver health, heart disease, weight, and thus they provide multiple benefits as opposed to something like perhaps insulin, which gives you very good blood sugar lowering, but that's about it. So that's enough of me talking. I hope you guys found this information helpful or informative, and I'm happy to answer any of the questions we have in our chat or otherwise.
Yeah, thank you so much, Michael. What a great talk. You went over so many different things. So clear. You actually have a lot of really great questions. And actually through your presentation also answered questions that had come in earlier. So we'll go over the ones that you have not answered. Let's start with Ozempic. Is there a big risk for gastroparesis?
So with all of these medications, there's a risk of gastroparesis. Gastroparesis is the slowing of the stomach emptying and the slowing of the digestion of food, right? Usually our intestines sort of move the food down, and that action is slowed by GLP-1s. If anybody has a history of gastroparesis, they should very carefully consider whether this medication would be appropriate or not, because it could make it worse. And gastroparesis leads to feeling very full. It can lead to nausea, vomiting. It's not comfortable. So yes, Ozempic does have a risk for gastroparesis, as all of these medications do, because it's somewhat built into the mechanism for it to slow down how fast your stomach empties. That being said, long-standing diabetes can affect the nerves that lead to our intestines, which also can lead to gastroparesis. So, there is a need to improve the sugar to avoid that same consequence as well.
Okay, great. And then does tirzepatide not provide kidney health or CV benefits, or do we just not have supporting data on it yet?
Excellent question. The correct answer would be we don't have the data. I think people presume these medications are beneficial for overall cardiovascular health based on a number of things. I think mainly weight loss and blood sugar control, but we technically can't say that for something like Mounjaro. The only ones that have proven that in trials are Ozempic, Victoza, and Trulicity. Same with kidney. The only one that's proven that in the trial so far is the Ozempic. But if one of those medications were not tolerated, or they're not available, or not covered by insurance, you could consider using an alternative one that technically does not have the indication yet, because there's a very likely chance that they do have it, but I guess we can't say that.
Okay, great. This is another question. Somebody's asking for Rybelsus, if you can only get the 3 milligram tablets, can you just double up, so have 6 milligrams instead of getting the 7 if it's hard to get?
Yeah, good question. So the 3 milligram dose is the starting dose of Rybelsus. You really shouldn't be on it for a long time. It's just for your body to get used to it. 7 or 14 is the approved therapeutic doses. Would it be okay to use 3 milligrams to get 6 milligrams? It's hard to say what 6 milligrams will do, because technically 6 milligrams wasn't studied. We can probably think about the fact that it'll be very similar to what 7 milligrams can do. I will say your main barrier to that is that no insurance will approve the use of twice daily or 2 tablets daily of 3 milligrams. And so unless you're paying cash price, which is pretty expensive for something like Rybelsus, you'll probably have an even harder time doing 2 tablets daily of 3 milligrams. If I were you, I would try to use the 7 milligrams instead, or use a different GLP-1 that is easier to obtain.
I think they were just mentioning sometimes it's harder to get that, but okay, another question. Is there a known link between these drugs and glaucoma as well? Because in your presentation, you mentioned sometimes eyesight with rapid glucose reduction, but this person saying because they've been diagnosed with possible juvenile glaucoma in their 40s and have been on GLP-1s for 2 years.
Yeah, so the main issue with GLP-1s right now is more retinopathy. I think there are some up and coming trials also looking at this, which is different than glaucoma, right? So when a medication has an effect, just because it affects the same organ doesn't mean it'll affect the same disease state process. So I would say for something like Ozempic or most of these GLP-1s, it's more of a retinopathy issue, and it's more of an issue of rapid glucose control, less so glaucoma specifically, as far as I know. But of course, if you have a more complex eye history, it's never a bad idea to, rope in your eye doctor to say, look, my regular primary care team wants to do Ozempic for blood sugar. Do you have any concerns for my eye health, since they are the eye specialist? But again, every risk has to be weighed against the benefit of what the benefits are doing for you, which is better blood sugar control and all these other protection. And what we also know is without good blood sugar control, we have very high risks to our eye health.
Okay, great. And then this person is wondering about the weight loss. Does it mostly come from fat weight loss? Because they've been reading articles showing GLP-1 receptor agonists associated with sarcopenia or muscle loss. So they're just wondering if kind of your thoughts around that, and if the fat and muscle, what are their percentage loss, and are they reversible?
Great. Yeah, great. Great question. It is definitely one of the hotter topics right now. From when we discussed GLP-1s with different manufacturers and the data on this specific breakdown of how the weight loss occurs, we tend to hear it's about a 1 to 3, like 3 pounds weight loss from fat, 1 pound from muscle. So there's definitely potential to lose muscle mass. Again, that being said, you have to weigh that risk versus the benefits of it. Reversible wise, when people stop these medications, I would say at least about half of people tend to gain at least some weight back. How much of that weight back is fat versus muscle, I don't know. I'm not sure if anybody knows. But in diabetes in general, it's important to stay active, which both includes cardio type exercises, but also resistance training that builds muscle. And I would say perhaps that's even more important if you're on a GLP-1 to avoid too much muscle loss.
Okay, great. Thank you. And in the Q&A, there are a lot of questions around bone. Someone said bone metabolism, bone reabsorption. That you mentioned that in your presentation. I did not hear it, but I said I would ask you to clarify.
Yeah, it's one of the things that the GIP section of GLP-1s, or sorry, the GIP section of Mounjaro can affect. To be honest, there's not, in the trials and the labeling, there's not a lot said about bone mineral density or like fracture risk or anything like that. But I assume we will sort of see more exploration into this, given that GLP-1s, pure GLP-1s, don't tend to have much effect on it, but the dual mechanism does have some potential effects on bone metabolism. I don't think I could go beyond that, but I assume we will find out more as Mounjaro is used more, but also potentially other dual GLP-1, GIP-1s get produced.
Yeah, excellent. Thank you for answering that. And then someone's asking, are there any adverse effects if switching between GLP-1s, for example, Ozempic to Mounjaro? Can you speak to that?
Yeah, there's no trial that says if you do this and then you switch, this will happen. So evidence-based wise, I can't point to something that says that. Now, in my practice, we do switch a lot of people from different GLP-1s. Sometimes it's because people don't tolerate it, so we have to move over to one to see if you tolerate the other one better. It's always possible, just because you didn't tolerate one, that you might tolerate the other better. Sometimes we switch because of a shortage. I'm sure people who take GLP-1s will be familiar with that. And sometimes we switch because we started with a GLP-1 that's less potent, maybe something like Trulicity, but we need more of an effect on blood sugar. And so we switch over to something a little more potent, like Ozempic or Mounjaro. When you switch, the switch itself should not cause any adverse effects, but you don't really ever know how you're going to tolerate that other medication. So typically when we switch, we try to go basically an equivalent or a dose down to ensure the toleration before we retitrate back up. On that same note, if you skip a dose of these medication long enough, like if you skip 3 to 4 weeks worth, it's likely that if you just restart at the same high dose, you will have some of the same side effects you may have experienced when starting the medication and getting used to it. Things like nausea, diarrhea, constipation. And we always recommend people do their best not to skip any doses. If you skip a little bit, like 1 dose or just a few days, it's probably not an issue. But if you take a long time in between, you might need to go back to a lower dose to sort of reacclimate and avoid side effects.
Yeah, excellent. Thank you for that. And then this person is just kind of asking, in your experience, I know you mentioned that sometimes there can be a little bit of weight regain after stopping medications, but what do you see in regards to blood sugar, so A1C, after potentially stopping?
I would expect to see the same thing, probably even more so than weight loss. As with any blood sugar medication, this is not specific to GLP-1, this answer. As with any blood sugar medication, if you stop it, the blood sugar will go up. Just like with a blood pressure medication, you stop it, the blood pressure will go up. That's because when we're using these medications, we are not actually reversing diabetes, right? We're not curing diabetes. We don't know how to do that at this point. We are basically working to ensure the sugar stays in good control to avoid all of the risks we know that occur with high sugar. And thus, we're just keeping the sugar under control. If we don't take the medication, you release the control, the sugars will go up. Depending on what medication will take more time, because these weekly injectables like Mounjaro or Ozempic last a long time, it may take a few weeks to see that arise, but it will definitely arise.
Okay, great. And then I think we just have time for one more question. Is there any discussion of the use of GLP-1 receptor agonists for post-gastric bypass patients with regaining weight after many years post-op?
Yeah. I mean, I'm not sure what the talk is on sort of the trial and what the industry is talking about. Personally, I have seen it used in my patients post-gastric bypass. I usually would do that in very close coordination with the GI team. So I think it's possible. It's not an absolute contraindication or anything like that. But if you were to consider that, you'd probably want to do it closely with the GI team to make sure that it would still be tolerable. You need to make sure that you're absorbing your nutrients. You're not super appetite suppressed. So a bit of a tricky one to answer, but I think it's possible, but it would require close monitoring.
Excellent. Thank you so much. You had so many questions. People were so engaged tonight. Really appreciate everyone who came. People are saying amazing, well presented. Thanks, very helpful. Thank you for answering questions. And so lots of shout outs in the chat. Thank you all for coming. Next month, we have Dr. Sakiri. He's presenting on what to ask your doctor about cardiovascular risk and metabolic health. So if that's an interesting topic, we hope to see you back on March 13th, 5 to 6. The same registration link will register you for all the talks in our webinar series. Thank you so much for coming. And thank you so much, Michael, for your wealth of knowledge and your detailed slides.
Thank you, everyone.